anterior chamber or the anterior uvea, we are referring to this section here. When we're talking about posterior uvea, we are talking about this section here. So this is pretty much here in this A, you can see the anterior chamber. They're referring to this anterior chamber, but this is the anterior uvea, the iris with the ciliary body. The pars plicata is where the fluid is produced from the ciliary body. This is the pars plana. So the thing about the iris, we also have to appreciate before I move on to the next slide, is that the iris is apart from being a delicate network of blood vessels, it also regulates the amount of light entering the eye, so it opens and closes. And the ciliary body, which is variable in different species, it comes in different shapes and sizes, supports the lens, and forms an integral part of the ciliary sinus. This is the ciliary body, and that's the sinus. And that's where the outflow of fluid exits from the globe. The choroid is this area, and this supplies the corneal aspect of the globe, including the retina and so forth. The blood ocular barrier has two parts. We call it the blood retinal barrier and the blood aqueous barrier. So this is just like we mentioned, anterior and posterior. The barriers are also anterior and posterior, right? We have two types, and they play a vital role in protecting the globe from external factors, not just external from the body, but external from your immune system. So they have these fenestrated junctions, non-fenestrated in the retinal layer, and tight junctions in the RPE, that's in the back, and non-fenestrated in the front near the iris. So these are important blood ocular barrier, which we need to understand this concept because this is what keeps the eye different from the rest of the body. And this is why sometimes when there's diseases and there's a break in the barrier, it causes eye diseases. So here we have a condition called iris hyperplasia. These are all developmental conditions. Generally, it's an incomplete development. It didn't develop properly, so it is looking a bit thin. And then there's also maldevelopment. Maldevelopment, we call it polychoria. That means let's say there was an extra hole here, apart from the iris pupil, that will be called maldevelopment. And then there's incomplete regression of embryonal tissues. So all this eye developed from the embryonal stage, and when the structures don't regress and it doesn't evolve to the mature eye, then you have all these defects. We call it the PPMs. We'll discuss that later. So if there's a major failure in the closure of the optic fissure, which is the embryonal section of the fetus where the globe develops, it's also where the skull develops and the eyes develop. Then we tend to get these defects here. So here we have what we call iris coloboma. See, we can't tell which iris is the original. Most likely the one on the left. This looks like a well-developed iris. The same here. And here you have multiple small colobomas all over. So the question is, it's hard to differentiate sometimes if this is aplasia, coloboma, or hyperplasia, because you need to see it at the right time to classify it. If it's at the juvenile stage, we have to call it aplasia. If it's in the senior stage, we call it hyperplasia. And if it's inherited, let's say it's in the family line, we call it coloboma. So earlier on, I mentioned about the persistent pupillary membranes. So during fetal development, there's a vascular network established in the anterior surface of the lens. So this is the lens here. And originating from the iris, it's part of the mesodermal arcade, or part of the mesodermal differentiation. So they supply the nutrition for the developing lens. And during the 6 week of gestation, somewhere around day 42, this this vascular structure is supposed to regress, and it will completely degenerate at birth. So we don't want any of this in the eye. And if it fails to regress, you have these abnormal structures left behind. We call these PPMs, persistent pupillary membrane, and they come in various forms. So they can either be uh, iris, iris to lens, lens to cornea, cornea to iris. There are various configurations. So it's just a classification. And I showed one picture earlier about the inherited issues. These are some of the common inherited PPMs. And depending on the nature of it, some are correctable, some are not. So we are just for you to understand that these are developmental anomalies. In some cases, you can also see increased pigmentation or altered coloration of the iris. So in this case, we call it heterochromia. You see, one iris is a different color from the other. Here you have black spots on the cornea, on the iris, and sometimes some of them look so obvious you may think it's a tumor when it's not. So we call this pigmentation of the eye, and they come in their own terms. So each of these different presentations has their own name. If we see a brown and white, we call it Merling. Hyperpigmentation refers to any form of pigmentation, doesn't have to be in one location, but not spread out this way. Here we call this nevi, Nevi. So all these terms mean that they're just pigmentation on the cornea, but we need to be able to differentiate a freckle, which is a smaller lesion like that, from a nevi, from a tumor, and so forth. So because they happen in young dogs, it's good to monitor the progress of it. Now, hyperpigmentation needs to be evaluated closely, as we mentioned earlier, for the following signs. Is there any distortion on the pupil? Like you see here, there's a distortion. Is there any pigment release in the eye? All this can only be seen under magnification. Is there any evidence of secondary pressure, glaucoma? And is there increased vascular supply? So once you start seeing these aggressive changes, we have to start asking ourselves, is this not just pigment or is it something else? So the uvea can be affected by both primary and secondary neoplasia. Primary means originates in the eye, and secondary is from another location. And the differential diagnosis for intraocular neoplasia should include all these non-neoplastic changes, including what we call uveal cysts and so forth. And the common most tumors in the dog is, in fact, the adenocarcinoma and the adenoma and melanoma. So these are common benign tumors, while in the cat, there's a species variation. They can be more aggressive, they tend to be diffuse, and they can spread. Another factor, the altered pupil is what we call dyschorhea. And here you have dyschorhea for various reasons. Here you've got a tumor, adenocarcinoma, causing dyschorhea. You have a blood clot sitting at the ventral chamber causing dyschorhea, and here you have a prolapsed iris causing dyschorhea. So when we look at the differential for neoplasiums, I think I mentioned this. The more common neoplasiums that are primary are adenocarcinoma, adenoma, and melanoma. While lymphosarcoma, which is very common in the dog and cat, tends to be more secondary metastasis. And so it's important to have a good clinical picture when you do your ophthalmic exams. In terms of intraocular neoplasias, the melanocytic melanoma is the most common intraocular neoplasia in the dog. This is a Where was that? This is a melanocytic melanoma. Okay, followed by the adenocarcinoma. And these lesions often are termed benign. So generally, the good news is they tend to just stay in the eye without progressing, versus the cat, where it tends to spread. And generally, these nodular growths need to be monitored. And general treatment in some countries include going in to remove it. However, because these are costly procedures, most owners may opt to choose the enucleation option because it's a risk factor to the rest of the body. However, we also have to keep in mind that the owners need to be educated on the fact that it's a tumor and what options are available. Here you have another form of neoplasia extending through the uvea and exploding out through the choroid. And here you have a ruptured choroid from the neoplasium expansion. Now, in dogs, the metastatic risk is about 4 to 6%, but in cats, it's about 63%. Here we have a different condition called a uveal cyst. They are quite transparent. They can be floating around or they can be mobile. These are treatable and they are removable through laser, or we have these devices to destroy these cysts. Um, it's also due to the failure of fusion of different layers. So this is also part of this mesodermal differentiation failure, and many of these cases can have visual deficits. If they are solitary or single, you don't have to do much, but if they are multiple, they can be complex. So here we have a horse with a uveal cyst, clearly pigmented, fluid filled, and in horses, we tend to suggest to have them removed because most of these are racing horses and they don't do well in their competition. Some of them can be attached to the ciliary body and some can be even attached to the cornea. So even though you remove them, the black stain remains. Hyphema is referring to gross bleeding of the eye. This is one of the negative prognostic factors for any eye. The moment there's hyphema or massive bleeding, the prognosis for vision and the prognosis for function is close to zero. The reason is for massive bleeding to take place, there has to be a certain amount of force and pressure applied to the surrounding structure. So, if it's traumatic, you need to look out for associated damage to surrounding structures. If it's intraocular, there's most likely a detachment or some tumor rupture. Ideally, any pet with a hyphema is a poor prognosis, and we generally recommend for them to remove the eye unless the pets are not in pain, they're not undergoing discomfort, and we can choose to leave it there as a cosmetic eye. So when you do an ultrasound of these eyes with the probe coming from the top, you tend to appreciate there's a lot of these. These are shadows here that you see sometimes with ultrasound, acoustic shadows. So here you're looking at a lens which is black and the rest of it in the eye that is white. And all that is the blood floating around. And then you see the retina. If this is the back of the eye, you can't even see the retina, it's detached. Probably this line represents part of the detachment. So, what causes a hyphema? There are many factors behind this because this can be an end stage pathology. Without understanding the history of how things go, it could be iatrogenic, post surgical. It might be uh, from someone's surgery that didn't go well. It can be also from a cataract that has ruptured. It can be from glaucoma, from an unresolved high pressure. We can also get it from breakage of the synechiae. Synechiae are adhesions that hold tissues together. Sometimes when you're trying to separate them, you may cause a bleeding. So generally, we treat them if the owner is ready to keep this eye going. We treat them with rest and drugs to reduce bleeding and to calm the pet down. Sometimes they can be quite challenging. It can take sometimes weeks for the bleeding to stop. But these bleeders do not affect the RBC of the patient. So, because they are contained within the globe, they tend to not affect the health of the patient, except pain and the associated discomfort issues. Uveal inflammation has to be classified again based on anterior or posterior. So if we go back to that eye diagram earlier, the front end is anterior uveitis. Here you have a fibrin clot in the anterior chamber, and the back end is posterior uveitis in the choroid. Exudate has to can also be classified based on the nature and the consistency. From the serous protein exudate that we see to the fibrin clots, sometimes we see that in the FIP cats, and hyphema, serosanguinous hyphema. And of course, at the picture below is the hypopyon, the purulent exudate. So this differential diagnosis is important if you're wanting to evaluate uveitis in any pet. Um, your list of possibilities need to be eliminated systematically and metabolic, including miscellaneous factors. Sometimes it's the vet that is causing the bleeding. For example, if your pet is already having some form of inflammation and you use steroids on it, that steroids will enhance the bleeding and sometimes aggravate the hyphema. So all these conditions need to be clearly understood and it requires a process of investigation. Fungal uveitis is not uncommon. We have identified plastomycosis and histoplasma in some cats. Cryptococcus also, but more in the nasal passages. So the climate is changing, and so the nature of the diseases could be also changing. Now, in the event that a pet develops a cataract and the cataract is not addressed on time, there's a condition called lens-induced uveitis, and this is when the lens cataract starts leaking out massive amounts of protein, triggering because it's leaking out into the eye that is trying to be inert beyond the blood ocular barrier. It causes and triggers an inflammatory cascade that with your cyclooxygenase and the lipoxygenase pathway. And these uveitis can happen very quickly in a short period of time, and surgery becomes warranted. Sometimes emergency surgery, but in many cases, when it's left too long, it may have to be enucleation if the glaucoma sets in. So there are two types of uveitis linked to the lens. We call it the phacoclastic. This is when you have a large volume of protein release, or what we call phacolytic, where you have a slow release of protein from a maturing cataract. The latter is a lot easier to control than the former. Now, if there's one slide you are to remember from this presentation, it's the aqueous flare, because this is the cardinal sign of uveitis. We call it the cardinal sign because if you can't see the flare, there's no uveitis, right? And out of all the signs, that indicate inflammation. This is the most important one, and it needs to be seen with light focused at the right angle and illustrated through the visual assessment. It's like driving through a dusty road and you're seeing the light beams through. So we classify the flare based on 1 to 4 or 5, and the more intense the flare, the higher the number. Another form of uveitis is what we call the fibrinous aqueous. This is, in fact, a very thick or chronic sort of inflammatory lesion. We tend to see this sometimes in FIP cats, and they also sometimes can form this lipid aqueous, so it goes very milky and white. Hyphema, as we mentioned earlier, is bleeding in the eye, and this needs to be treated aggressively or the vision is lost. The same with hypopyon. Once there's pus in the eye, underlying factors to be investigated. So some of the clinical signs of uveitis includes photophobia. That means the inability to tolerate light. They become very light sensitive. They have a ciliary flush. This is the fine brush border vessels on the cornea. And of course, the corneal edema, where the cornea starts getting cloudy, right? Now, when there's this aggressive inflammation, often due to whichever factors that are taking place, the uvea functions like a lymph node. So once it's traumatized, it gets very reactive. And these factors that are being released in the eye, the prostaglandins, the oxygen free radicals, all these are cytotoxic and they become a common denominator of tissue damage. So histamine, arachidonic acid becomes an important part of the management of the cascade. And the more arachidonic acid is released from cell damage, the more inflammation develops. Prostaglandins are produced as a result of this arachidonic acid cascade, and they result in the miosis, the shrinking of the pupils, the redness, and of course the altered intraocular pressure. So here we have an example of miosis. Maybe not a good picture, it's still dilated. The one below is more appropriate for miosis, followed by spasms in the ciliary body. And the one above is more relevant to the second point, which is precipitates that deposit on the cornea. Sometimes tissues, this material become like glue and they stick things together and you get synechia or adhesions. So here's an example of what we would term keratotic precipitate. It's another form of fibrin deposition. And then if you look at these are all immature T cells, B cells, lymphocytes, macrophages, monocytes. So it's very clear that the blood ocular barrier is damaged in order for these cells to get into the eye. So some of the other signs of uveitis includes rubioiris or red iris, cataracts. Rubioiris can be also referred to this redness that you see here, the cataract there, and the whole iris that is turned red. Pre-iridial fibrovascular membranes, that's a membrane that forms from chronic uveitis, just like you see in this picture here. And then you have decreased IOP, intraocular pressure. The pressure goes down, and in some cases, glaucoma can develop secondarily. So the common signs of uveitis include blepharospasm, pain, epiphora, red eye, photophobia, corneal edema, flare inflammation, fibrin clots, and keratotic precipitates. Of course, out of all this, the aqueous flare is the most important to confirm uveitis. Clinical signs include chronic cases. Sometimes you get discoloration of the iris, discoloration of the cornea, increased pigmentation of the eye. In some cases, the lens can subluxate due to breakdown of the lens fibers. From this unhealthy environment, the structures are degenerating. Chorioretinal degeneration. This refers to retinal. This is happening in the back segment of the eye, where the retina and the blood supply shrinks, and of course, secondary glaucoma. So these are the signs of chronic uveitis, and this is the sign of acute uveitis. So we have a differential here to differentiate between acute and chronic. So even though the client tells you it's this just happened yesterday, if you have a look at the factors, you can tell it's not a yesterday's issue. It's probably been a period of time. So here you've got retina with some posterior segment. The retina has some hemorrhage, old scars. This is a chronic lesion. It had ruptured previously and it is now left a scar. Here you have some inflammatory changes. On the right here, you have hemorrhage just under the iris, under the retina. So the optic disc, which is the center part of the retina, is now obliterated by this blood clot. So generally, the investigation for uveitis requires a clinical exam. So clinical, we mean head to tail, not just the eye. And then we perform a blood smear exam, rule out systemic factors, and so forth. And of course, once you've understood the factors, then only you initiate the treatment, of which all these drugs are appropriate for inflammation. However, they all have their indications and their contraindications. So please understand their positives. In the event of a fresh bleeder, I would avoid from any anti-inflammatory because it will enhance bleeding. But all these are effective tools. Sometimes surgery is required. And so that takes us to the end of the lecture. So are there any questions on the uvea?
Got one question in the chat box, Doctor.
Sure. Missed, but does the anterior uveitis happen more often than posterior? And is the vision of anterior more reversible? Okay. In the event of anterior uveitis, they can happen independently because, as I told you in the initial slides, we have two blood barriers. We have the blood anterior ocular barrier, which is broken up to the blood retinal barrier and the blood uh, uveal barrier. So when there's anterior uveitis, you don't necessarily need to have posterior uveitis. That is true. However, you can have pan-uveitis. That means both anterior and posterior are inflamed. And it is true that the anterior uvea is easier to address because it's more visible. However, uh, because they are harder to detect in the posterior segment, if you're not able to evaluate that, you won't be able to distinguish if it's anterior or posterior. So, in the event of when the uveitis develops through all the prostaglandin release, it destroys the. This is to the next question: why the IOP is decreased. So you will understand that in the next presentation, actually, when we talk about glaucoma, because it's in fact a direct correlation between the inflammation in the ciliary body and the way the fluids are manufactured out through the different pathways. We have different pathways, but I think I'd rather save it for the glaucoma talk. Okay, if that's the case, then we'll move to the glaucoma section. Right. So glaucoma is not just a disease of pressure, like most people think. It's actually a complex pathway of diseases resulting in visual loss. Right. So glaucoma is not just a disease of pressure. In fact, studies and repeated studies have shown that in order for glaucoma to be classified as glaucoma, there needs to be a series of factors. And because the endpoint is, of course, visual loss, as you can see from this picture, a person with glaucoma will slowly lose his vision. And so it is important that we preserve the integrity of the globe. And so, just to recap what I mentioned, the glaucoma is defined as a group of ocular diseases that are detrimental to the maintenance of vision. So, other than the intraocular pressure, you have hereditary factors, you have eye movements, you have physiological state, right? You have anxiety factors. If you get excited, your heart rate goes up, your eye pressure may go up, decreased blood flow. Also, if you're restraining a dog and you're holding him very tight, his eye pressure may go up. You have glutamate toxicity factors, neurotoxicity. So these are all internal physiological pathways. We also have issues where there's myopia. Myopia can also trigger glaucoma in some patients, but in animals, we don't focus so much on myopia since uh, most clients are more concerned with the pet being able to see rather than the long sightedness and the short sightedness. But we have tools to measure long sightedness and short sightedness. So, glaucoma has to be defined in 5 stages. It's a series of events. And basically, when there's an obstruction of outflow, so back to your question, once there's inflammation or uveitis, prostaglandins are released, your arachidonic acid cascade is active, there's destruction of the red ocular barrier. Sometimes there's also reduction in production. So if you imagine a tap, when there's pressure up, it can either be that there's an outflow issue or there could be an increased inflow issue. So in this case, with uveitis, there's a reduced flow from the tap while the drain is still the same flow. With glaucoma, you're probably going to get a reduced outflow and an increased inflow. So this would apply to the concept of increased IOP. Now, what this happened, the moment the pressure increases, it puts pressure on the optic nerve and it alters the nerve conduction through the myelin pathways, and then concurrently destroys the retinal ganglion cell, which are important cells in vision, and in the end results in optic nerve degeneration. So here is the outflow pathway, or what we call the drainage angle. Fluid is produced from the ciliary body through the pars plicata. They then migrate out through the lens space, through the pupil, to the front chamber, and then drainage back to the iridial corneal angle, or the ICA. This is the ICA. And from the ICA, it goes back into the venous outflow. So the aqueous humor production is a transparent ultrafiltrate of plasma, and it's 2% of the anterior chamber volume. That's how much aqueous humor is produced at a time per minute. And so the components of aqueous humor include protein, immunoglobulins, enzymes, lipids, carbohydrates, and so forth. So this fluid is an ultrafiltrate and it's produced through the blood ocular barrier by various pathways. The first pathway is the passive diffusion through blood ocular barrier, and it requires just a standard physics diffusion pathway from high concentration to low concentration over a tight junction at epithelium. The second pathway is through ultrafiltration. This is when hydrostatic pressure differences between the oncotic pressure of the ciliary body and the pressure outside drives the fluid from the blood vessels out into the aqueous. This is these two layers of cells. You see here the non-pigmented and the pigmented. This is the blood ocular barrier. Then through active secretion, we can also produce aqueous through active pathways. So earlier on we talked about passive. Now we have active pathways. We call this the bicarbonate pathway, the first one, to the conversion of bicarbonate, electrolytes move out. And the second is through sodium potassium pump ATPase. And this drives the production of aqueous humor. So keeping in mind all these different pathways, now we should look at the drainage outflow pathways. So in order for aqueous humor to exit the eye, it can only exit through its ICA, uveal corneal angle, and it has two methods. One is what we call the conventional flow, which is somewhat like a diffusion flow, going through point 1 and point 2 of the arrow. And then the second pathway is by the uveal scleral flow, that means it diffuses through a different pathway and exits through a different way. The functions of the aqueous humor is to maintain the intraocular pressure. And the reason why it's important is because the cells are sensitive to pressure, as well as to provide nutrients and to remove the waste. Failing to maintain this pressure will cause disease in the eye. So the classification for glaucoma can be broken up into primary and secondary, of which primary glaucoma is often related to inherited structural factors, while secondary glaucoma is associated to diseases that are ongoing in the patient, driving the high pressure. In primary open-angle glaucoma, the first form of primary glaucoma, the angle of the eye is open. We will try to do this at the practical to see if we can do it. Although I'm not sure if our patients will be very cooperative, but we can actually appreciate the view of the open angle here. The white area is the angle, the brown area is the iris. While in the closed angle, in the next diagram, because it's closed, all you see is black. So the angle is closed. We also quantify modified percentage of exposure. So we grade it like a clock, 10% to 100% to monitor the progress of it. And in closed angle, we have a term that we call corneogenesis, and there are types of corneogenesis. The secondary glaucoma is far more common than primary, and so include factors such as lens fluctuation, between disease, mature cataracts, cancer, uveitis. We spoke about that. In terms of cancer, we spoke about how it altered the dimensions and glow, and of course, deposits. And we have uveitis, lens uveitis, phacocytic or phakic. When we classify secondary glaucoma, just like how we classify uveitis, primary or secondary, we do the same for glaucoma. We can also classify acute or chronic. So there are many ways to classify glaucoma. And here you can see in the picture here, a lens located and situated in the anterior chamber. This is a surgical case which causes a lot of pain and discomfort. So we are generally going to remove these lens, and sometimes it can be functional as usual, depending on the duration of the lens fluctuation. We also have functional prolapse. These are conditions that generally affect the eye, migrates forward, long cataracts, and so forth. Here you have the aqueous gland in the front. As we look in the back of the eye, you can see this floating material chamber. This refers to the prolapse nucleus leaking out from the back chamber into the front chamber. We also classify it based on cataracts as we see. So any cataract or concurrent glaucoma is classified as secondary glaucoma. Tumors in the eye, severe uveitis. You can appreciate that the iris is swollen, puffed up forward, and completely obliterated. You can't even see the structures inside. And of course, we spoke about hypothyroid, the risk of altering the pressure because all these cells are floating there, could be blocking the brain. So what are the signs other than the general appearance? We spoke about earlier when we did conjunctiva, the superficial and blood vessels. So these vessels you see here are the deep conjunctival blood vessels. We call this episode of congestion. Of course, there will be pain. Glaucoma patients always have pain and discomfort. There will be clouding of the cornea. It's supposed to be dilated. The optic nerve will be destroyed or depressed. ERG refers to a very specific electroretinogram test that we do here to measure retinal function before surgery, so that our clients at least understand the condition of the patient before they proceed. Signs of acute glaucoma can include pain again with corneal edema, dilated pupil, optic nerve clumping inside, and a normal ERG. So in the event of should this condition not be adequately controlled, it will slowly destroy the retina and result in a very unhealthy looking optic disc. Once the condition has been left too long unattended, you can get more chronic signs of glaucoma, including these abnormal lines that you see, as well as the edema. And all these are indication of chronic changes in the eye. Most of these patients probably will not be able to see at this stage. And that's why the signs of retinal atrophy and the ERG test will be absent. In the case of chronic glaucoma, in the case of this cat, you have this gross abnormality in the size of the globe. Now, it's not necessary for every big eye to be removed unless it's causing a problem. So we always do no harm until necessary, and that is the better way of doing it rather than removing every eye that you see that looks abnormal. Signs of chronic glaucoma can also include iris atrophy. Here, the iris is shrinking, creating these big pockets where you think it's maybe due to an ongoing aging factor or inherited issue when it could be due to glaucoma. And of course, you have lens luxation and subluxation. Optic nerve atrophy, again, there's no more blood vessels on the retina. We'll discuss this during the practical. Retinal atrophy. And of course, the techniques we use to measure. So, Other than the visual inspection that we talked about earlier for the acute and chronic signs, we also have tools to measure. The instrument on the far top is called the Shayot stenometer, and this is a traditional way of measuring pressure. I don't believe they sell them anymore, but the weight is applied on this scale, and the patient is positioned with the head upright, and the scale is dropped on the cornea gently, and the measurement is taken there. So that's called an indentation tonometer. Then we have on the left a tono pen, which I think they use at the UMK, and it rebounds off the cornea. They just bounce it off the cornea and it takes a reading. This is called an applanation tonometer. And the one in the far right is called a rebound tonometer. It's just a pin that bounces off. Now, each instrument has their pros and cons, and each instrument has their ranges. In other words, if you use a tono pen, which is on the left, keep using the tono pen. Don't keep changing between one instrument and the other. If you use a tonovet, use that and don't keep altering because the pressure measurements can be different. Conioscopy, we actually apply a device on the globe and then we take measurements and we get to appreciate the angle here of the eye through a magnified light instrument. And when you have a good view, when it's magnified, you get to appreciate the pectinate ligaments. And here you get to visualize the closed angle. So in the case of emergency where there's severe pain, you've checked the IOP, the pressure is high, and all the signs of acute glaucoma are present, not chronic glaucoma, only acute glaucoma, then this protocol is effective in reducing the intraocular pressure, where we give intra-IV mannitol or glycerin to reduce the systemic pressure, at the same time reducing intraocular pressure. Concurrently, sometimes we use anti-inflammatories, as we had shown in the last slide, and these are to reduce the inflammation in the eye. In very rare cases, we will sometimes aspirate fluid out from the globe, but this is not a long-term solution, and it can also create a risk for asepsis of sepsis. If your technique is not sterile, you might introduce bacteria into the globe. So we don't recommend that method, but the first two methods are commonly employed. Medical treatment of glaucoma includes modifying the pathways of all the methods that create aqueous, including the use of carbonic anhydrase inhibitors to reduce the bicarbonate pathway. You've got alpha agonists to reduce the alpha agonist pathways, and you have beta blockers to alter the beta blocking pathways. So each of these methods have their pros and cons. Not all patients tolerate all the drops, and so generally we suggest to work on them systematically, but only to be used once glaucoma is confirmed. For other pathways available, if the first method of drugs don't work, then we have alternative drugs to alter the flow of fluid out of the eye, including cholinesterase inhibitors and prostaglandins. These drugs, prostaglandins, you can't use them when there's bleeding or active inflammation. It will aggravate the uveitis. Medical treatment of cats, you have to be careful on the drugs that are used. Some alpha-2 agonists are toxic to cats. So there are some products that should not be used in cats for glaucoma. Carbonic anhydrase are safe and beta blockers are safe. However, sometimes the effects can be limited. And in the case of alpha 2 agonists, as I mentioned earlier, if you use this in a cat, it can suddenly cause the blood and the heart rate to drop, and you can have sudden collapse. So you have to be always aware of these complications when you use the drugs. Medical treatment of cats has to be a bit cautious because they have a different physiological pathway for inflammation from dogs. And so some of the drugs that we mentioned earlier, the prostaglandin analogs, they are not appropriate for cats, right? So cats are not small dogs, and generally they tend to require different methods of treatment. Surgical treatment for glaucoma includes cryotherapy. We also do liquid nitrogen cryotherapy to reduce the ciliary body outflow, and in some cases, placement of surgical valves like they do in people. However, in animals, these valves are not as effective. They get blocked very easily. So, generally, the treatment of using cryotherapy or laser ablation is still the more preferred method. In terms of intraocular gentamicin, this has been done by some vets in general practice. It's if any one of you have ever administered gentamicin subcutaneously in a pet, I think you'll understand how it stings. It's very acidic. So just imagine injecting it in the eye. It's a very caustic product, and it's because of the caustic nature, it's supposed to destroy the ciliary body and reduce the pressure. But on a welfare perspective, this is not a procedure that I would recommend when there's no monitoring or adverse control of the side effects. I've seen some cases where they come in with very painful eyes. Despite the procedure being successful, the eye remains painful for 2 to 3 weeks thereafter. And so it's not a very good welfare aspect. So I wouldn't recommend intraocular gentamicin. But in cases where options are limited, yes, of course, it is a treatment option, but the owner needs to be informed. And of course, here is an example of intraocular laser where we kill the ciliary body following a pathway of application. Here we have a patient where we've placed an Ahmad valve, and these valves are not the greatest, but they are also effective in controlling glaucoma. And of course, when all fails, because glaucoma is a degenerative and a destructive disease, then we have to go to the discussion of enucleation and evisceration. Any questions from this slide? Sinian, is it Sinian who asked the question? Yeah, hopefully that presentation explains the IOP issue. It's a complex pathway of production and reduction.
Hi, doctor. I have a question for the primary glaucoma.
Yes.
I don't understand about the open and the closed angle. So, what is normal?
Okay, so normal is to have an open angle, right? But here we are classifying a primary open angle, not a normal open angle. You understand the difference? So when we talk about primary open angle, the angle is open, but the fluid is not draining out. While in a normal patient, the angle is open and the fluid is draining out. Does it make sense?
Yeah. So we determine that the fluid is not flowing out by the IOP, is it?
Yes. So you
Okay.
determine the fluid is not flowing out by the IOP as well as all the signs we described about glaucoma. So once there's a glaucoma, we know the fluid is not flowing out, right? That's clear. Now the question is, what is causing the fluid to not flow out? That needs to be investigated.
Okay,
Does it
thank
make
you.
sense?
Yep.
Yeah. It's like a sink analogy. The tap is open, but the drain is not flowing. Okay. There's no questions. There's one last presentation on ocular emergencies. I think this is quite useful. So I'm going to put that up. So I think all these slides I've given are in your have been shared. Now this is basically an outline of things to do in the case of an emergency because, as you know, in private practice, sometimes you are having to deal with things at the front end, and you need to be able to make some, maybe not all the decisions, but you need to be able to make some fair decisions on what to do with the patient because all these are important topics. So the first and foremost is called proptosis. This is when the globe is displaced out of the orbital rim, and due to either trauma or some sort of event, it has to be forcefully expressed out of the orbit. So, in other words, there has to be some major involvement. And certain breeds are more predisposed because of the shallow socket and the weak eyelids holding the globe in place. Just you'll probably see a lot of these brachycephalics coming in with popped eyes sometimes. So it's important to make a prognostic decision whether these globes are to be saved or removed because these are ethical, welfare, as well as legal issues. Some owners get quite distressed and then they feel like we have made a wrong judgment call when actually it may be the right one. So it's very important when an emergency comes in that you're able to at least first classify and define what you see and then be able to convey that message to the owner on the urgency. So, in order for us to understand proptosis, we have to first understand the anatomy. Um, I think, do I have slides here? No. So, generally with proptosis, the globe has been pushed over the socket, and I think I have a slide that better describes it. But let me try a different one. Because we are doing lectures for the third and fourth year separately, I've split the topics. So we have, let me go to the relevant topic here. So this is proptosis. The globe has now gone beyond the optic rim. It has now, it looks obviously to be removed, but the owner has to be convinced why, because there's a lot of pain, discomfort, and it's pointless trying to replace this globe back in. But more importantly, is the relief and the comfort. Is a welfare issue. So, in order to be able to make conclusions on the globe, we have to look at the viability. So, we look at the structure of the globe. Is this viable? So, the globe has to have a normal structure. It cannot be having any loss of dimension. So, this picture here is viable. There's no rupture and there's no desiccation. There's just some clouding. Then we look at the position of this globe. Is the globe looking straight at you as it should, or is it deviated? So generally, the eye muscles, 6 of them, hold the globe in position. And so when the eye muscles rupture, they tend to deviate to the side of where the tension is. And so that will indicate to you the number of muscles torn. Generally, most of the muscles that tear are in the medial side first because it's shorter, followed by the relative muscles. So because a lot of blood supply comes in, as I showed you earlier in the uvea slide, through the ocular muscles, when 2 or more muscles are ruptured, the eye should be enucleated because you've compromised blood supply to the globe. And it's going to cause a lot more complications. So when we say more than 2, sorry, not 2 or more than 2, so 3 or more, you want to have this globe removed. And as I showed you earlier on the slide on uvea, when there's hyphema or bleeding and the globe is filled with blood, these eyes should be removed. Unless, of course, the pet is compromised and is not fit for anesthesia and the owner wants to keep it there and there's no evidence of pain, then it's worth keeping it. But most of the time, they should be removed. And of course, we do not pay much attention to neurological function during a proptosis because everything is swollen at this stage. So our first priority is to decide, is this globe to be removed or to be kept? And if it's to be kept, we then replace it back into the socket and then reevaluate it 2 weeks later to decide if the function of this eye is viable. So I would strongly advise not to tell owners that the eye can be fixed. You need to be very clear what you're trying to tell them. Rather, tell them that you are trying to replace the globe and reevaluate its function later. So here are some different pictures of globes here. Which of this globe should be preserved? Or which of this globe you think even can be saved? Or none can be saved? It's a trick question.
None.
So one person says none. Anyone? All agreeing with him? None?
Yeah, might be none, doctor.
None. Okay. I think these two are pretty obvious. But this one here, I would probably argue to say that it is still possible because if you can see, there's just bruising on there's no evidence of muscle tear yet. Can you see the globe is still in position? It's just pushed out. You look at the opposite eye, can you see it's still in the same angle as this eye? So the muscles are intact, there's some bruising. So this eye should be saved, right? So this is an example of the kind of decisions you have to make in practice with regards to proptosis. So these are eyes that sometimes can be rewarding if you do it on time. So how we perform this procedure is that we first ensure that the pet is sedated and fit for anesthesia. Then we lubricate the globe and protect it with lubricants because it's exposed. You don't want it to dry up. And then you have to gently place your forceps to grasp the eyelid margin without traumatizing the eyelid and then retract it outwards as you push the globe in. So you may need an assistant to help you here, but it must be done gently and not forcefully, or you might cause bleeding in the eye. And then you return this globe back into the socket. Once the globe is in the socket, then we place a suture on the eyelid margin as we would do here. Wait. Then you place sutures on the eyelid margin, horizontal mattress, keeping the sutures away from the eye, and then you bring the eyelids close. So that holds the globe in position. So this will stay on with some cold packs and anti-inflammatories for 2 weeks until such time you open up the eye and reevaluate the structure. In the event that the eyes are too traumatized, then we should enucleate the globe. There are a few methods for enucleation, but the most recommended method is transconjunctival and basically involves making an incision through the conjunctiva, undermining the entire conjunctiva until you get to identify the muscles underneath, then ligate and resect all the muscles around the globe, and then carefully with scissors resect the optic nerve bundle at the back and remove the globe. Avoid too much traction. This picture is not showing much traction. When I say traction, you're pulling it much further out, and because in cats the optic nerve is quite short, so if you were to pull too hard, you might cause blindness in the contralateral eye. So that's another big issue. So you don't want to have two blind eyes. So you'll have to work gently, cutting and resecting. And once you've resected, immediately there'll be blood. Roll up a gauze and apply gentle pressure into the orbit until the bleeding stops. Takes about 2 minutes or so. No ligation, no sutures inside. And then once the bleeding stops, complete your closure of the eyelid. So with the nucleation, you're removing the entire content of the globe, excluding the muscles and the optic disc and optic nerve, but just the globe itself. And this is an effective way for end-stage glaucoma. So this is and many end-stage issues, including trauma, right? In the case of exenteration, this is a procedure that we do when there's cross pathology in the eye, maybe massive infection spreading to the surrounding tissues, maybe a tumor in the globe that you don't want to spread. In this case, slightly different technique. It's trans eyelid. So basically, we close the eyelid up with forceps, then we cut elliptically around, followed by gentle dissection right up to the bone of the orbit, resecting the globe, and then tying the entire bundle. In this case, you need to put sutures because you will not be able to stop the bleeding from this resection. You will need to ligate it. So even when you ligate it, avoid applying traction on the optic nerve, and then we close the eyelid. So in this case, for an exenteration, you remove the entire globe, right? So these are procedures of enucleation done well, where it's smooth. In some cases, some clients may request for prosthesis. There are specific prosthesis so that the eye doesn't look like that. So it looks a bit more. But in my opinion, it's not important. End of the day, it's the welfare of the pet that is more important. So these are just in Europe and US. Sometimes they do it um, as a procedure, but I think it's not ethically necessary for dogs and cats, right? Okay, so with that, I'll go back to the past slide. Does everyone get the idea of the enucleation and proptosis and when to save the eye? Okay, there's a question here. During an emergency, if salvageable, but we are unable to place the eye in the socket, not fit. How long can the eye stay externally? Uh, to be honest, we have to find a way to put it back. You can't leave it out. You cannot lubricate it. Depends. You see, if you look at those pictures that I shared with you earlier, it's close to impossible to try to bandage and keep those eyes going for days. Maybe for a day or two till you solve what needs to be done on the patient to get him safe enough for surgery. Maybe, but I doubt you'll be able to keep those eyes outside for long. End of the day, if let's say the clinic is not able to handle the procedure, it needs to be referred to a center that can do it safely. Because anesthesia is down to the experience of the clinician as well as the ability to handle complex cases, you see. So it's subject to the situation. And is there any way for the great globe proptosis to grade globe proptosis, or is it more of a subjective evaluation? No, it's a very objective. It's not subjective. Globe proptosis, as I showed you earlier, is very objective. Where's that slide? We look at the viability of the globe first thing. So it's either viable or it's not viable. There's no subjective there. And then we look at the number of muscles torn. It's either more than 2 or less than 2. And then we look at the blood in the eye. It's either hyphema or no hyphema. And then we look at the cornea integrity and the pain and the pus or whatever it is in the globe. It's either there or not. So it's not subjective, it's quite objective. And there's about 6 or 7 criteria that have to be considered before you remove the globe. Like in the case of the 3 pictures I shared just now, where is that picture? Where's the picture I sent? Just a minute. Okay, the picture of the orbit. So it's very obvious. Of course, this is a bit difficult in a picture. You're not seeing the pet. Here you have to make a decision based on a picture which is fair. So I don't expect anyone to get it fully right. But in this case here, the criteria has been met. So there's no reason for you to resect the globe. In these 2 cases here, I do agree the criteria has been indicated for resection. So it's very objective. It's very unlikely you're not going to be able to make a judgment call. Of course, you have to see more of it to be able to make a better call. But ideally, it is very clear cut. Okay, so we'll move to the next topic on this. Oh dear, wait just a minute. Okay, so proptosis we've discussed, and we've identified the importance of classifying. So here I've given you a very clear PowerPoint, a little lecture notes here on decision making. Favorable, unfavorable, very simple, right? So in the event that all these issues are ongoing, in the event that there's damages to the muscle, then the prognosis changes. That's all it is. So proptosis, as I mentioned at the bottom here, is a true ocular emergency. And yes, of course, there are health risks present, but you have to address those health risks and then get down to having the surgery done. Then the next one is, I think we spoke about this, surgical replacement of the globe. I put some notes there. And then, of course, about acute glaucoma. We spoke about this in the glaucoma section, where you use mannitol therapy in the acute phase to reduce the pressure, as well as drugs according to the classification of the glaucoma. So I'm going to skip that since it's already been explained and it's well illustrated there. So here in emergency treatment, normal intraocular pressure for a dog is about 20 maximum, can go up to 25, but anything above 30 is bad news. So basically in a cat, that's different. In a cat, 30 millimeters can be considered normal in a cat, because you also have to evaluate the pressure along with the anxiety level of the patient and the condition. So in cats, the top level of IOP limits are slightly higher than in a dog. And in a rabbit, it's a lot lower. So, I mean, all this breed variation is necessary to know if you wish to take measurements. And then we go down to the next emergency, which is deep ulcerations. And basically, what we need to do to diagnose it, and of course, we need to classify the lesion. And here I've got a nice chart here to give you an indication what are the benefits of each therapeutic method. So, in terms of the dash, it means very little, and question mark means it's still present. There is some protection there with acetylcysteine EDTA, but it's hard to quantify the advantages, but there has been proven literature on that. And then, of course, the other drugs and the classification here on its use. Of course, the two surgical methods, third eyelid flap and the conjunctival flap. You can see the benefit of the conjunctival flap over the third eyelid flap. So there's no support, there's no protection. Although some people think they are protecting the eye, all you're doing is just maybe reducing some pain, but in a mild way and providing very mild support, but not the adequate support needed for the globe. Right? And then as we go further down, it talks a bit about the drugs and some of the therapeutic options. Iris prolapse, this is an interesting section, but this requires it's not easy to do this in general practice. You need equipment to and ophthalmic equipment and microscopes to correct this. But ideally, these are ocular emergencies, including desmetocele. So desmetoceles are corrected using a conjunctival graft or an amniotic graft, right? The same with the corneal laceration. Sometimes we suture up the cornea or we place a graft on it. So I'm just running through this because this is reading material for your own interest, and some of this information will be practical for important for private practice. Okay, so in terms of anterior lens luxation, maybe I'll just spend some time on this. There are different types of luxations. We call it subluxations. That means it's loose but it hasn't fallen yet. And you have actual luxations where the lens is in the wrong place. So classifying the luxation is equally important because when the lens is in the front chamber, it's a lot more painful than when it's in the back chamber. And so I have the literature on that to just run through on the details. But basically, what I'm trying to say is if a patient has a lens luxation where the lens has fallen to the back, you have the option of leaving it there and managing it conservatively, compared to a patient where the lens has fallen in the front. This is surgical. Because this is very painful. So you can notice in ophthalmology, a lot of the decision making is based on the comfort and the welfare of the patient. And if it's not causing pain, there's no need to intervene. If it's causing pain, you should intervene. Okay, so I'll leave it at that. Any questions from the students here?